This program is about therapeutic communication and the challenges presented by dementia and aphasia. After completing this lesson, you will be able to describe 2 common behaviors you may observe in the patient with dementia. Identify one way to deal with each behavior. Define reality orientation. Describe 2 problems the aphasic patient may experience. And identify one strategy to deal with each problem.
Communication, the giving and receiving of messages. Everyone depends on communication to meet their basic needs. We know that words can separate people or bring them together. The better we communicate, the better we will understand and get along with others, and they with us. We have learned that communication is a 2-way process. The sender originates the message, encoding it into symbols he hopes the receiver will understand. The receiver must decode the message, or translate it into something he will understand. The receiver then becomes the sender through feedback, a response of information or questions to verify or clarify the information. Hopefully everything comes together, so the messages on both ends will match, and there will be understanding. We have also learned about therapeutic communication, the communication with your patients that must be caring, helping, and healing. Therapeutic communication utilizes all the basic effective communication techniques and empathy to assist your patient to meet the goals of care and to achieve the optimal quality of life. You may realize, however, that maintaining therapeutic communication is not always easy. There are many things which can interfere with communication with your patients, such as problems with speech, language, hearing and vision, certain diseases, mental illness, and more. In this program, we will focus on 2 specific conditions which you will encounter. The patients with dementia and the patients with aphasia will challenge your communication abilities. We will identify these challenges and discuss strategies to help you maintain communication. Let's discuss dementia, the first condition which interferes with communication. The patient with dementia presents a real communication challenge for caregivers. Dementia is not a diagnosis or disease. Rather, it is an umbrella term for a wide range of symptoms caused by disease or dysfunction of the brain. These symptoms are often clustered under the term cognitive impairment and can include impaired judgment, thought, memory, reason, understanding, learning, and knowledge. With loss of memory and intellectual functions, the patient usually demonstrates changes in attitudes, personality, performance, and behavior, which can vary between different diseases and between different patients with the same disease. Dementia is not a normal sign of aging. It can occur at any age. There are a variety of disease states that cause dementia, including brain tumors, infections, and trauma, nutritional disorders, toxic effects of chemicals and drugs, and strokes. By far, the most common cause of dementia is Alzheimer's disease. Little is known about the cause, prevention, or treatment. In Alzheimer's disease, an unstoppable force yanks and twists at the nerve fibers of the brain switchboard, tangling thoughts and confusing symbols, until finally the wires are hopelessly crossed, and one is disconnected from all conscious interaction with the outside world. This mental impairment interferes with the patient's ability to manage even the most simple daily activities, and usually leads to severe mental decline. Because the symptoms of Alzheimer's disease are typical of individuals with dementia, we have chosen Donald to demonstrate how to communicate with the patient. Donald was diagnosed with Alzheimer's disease 4 years ago. Before you meet Donald, let me give you a history of his illness. Donald was a salesman for an aluminum siding company in the Midwest. With hard work, a homespun sense of humor, a congenial personality, and gentle hard sell, he built his territory into the biggest and the best. But after 34 years, he began to have problems. Orders he insisted he'd placed would not come through, and no one could find an invoice. Old customers were surprised, not only by mistakes, but by his defensive and rude attitude. Donald became antagonistic and suspicious toward coworkers. A trickle of isolated complaints grew more steady, until finally Donald's manager suggested he take some time off. "You just haven't been yourself lately," he told Donald. "Get some rest. See a doctor." Donald was angry and frustrated. He knew something was wrong, but he couldn't put his finger on it. He'd miss important sales meetings. One day he was on the road and couldn't remember where he was going or who he was going to see. It was the most terrifying experience of his life, and it left him shaken. Confused and hurt, he took an early retirement. After retirement, Donald's symptoms gradually worsened. He'd sit for hours doing nothing. He couldn't decide what to wear. When Ruth laid his clothes out, he put them on all wrong, and finally needed help to dress. He accused Ruth of stealing his food and money. Donald was indeed exhibiting typical signs of a dementing disease: forgetfulness, delusions, difficulty performing familiar tasks, impaired judgment, confusion, and disorientation. After a thorough physical, neurological, and psychiatric examination, his doctor was fairly certain that Donald had Alzheimer's disease. How do you communicate effectively with someone who cannot remember, understand, or think clearly? How do you deliver care and work toward the goals that are set for the patient? Each of your patients will be functioning at a different level, and you will relate according to their capabilities. Your care plan, along with the help and intervention by the nurse, speech pathologist, and other professionals, will provide helpful information and directions for individual patients. There is one golden rule to remember when caring for the patient with dementia. The patient is not responsible for his actions. There is nothing your patient can do to change or control his behavior. Do not take the patient's actions and comments personally. Do not respond with anger or frustration. We must remember first and foremost that dementia is a disability, much the same as a fracture. We don't get upset if the patient with a fractured hip cannot walk. So we should not get upset with the patient whose brain is disabled by dementia. As we look more closely at the problems the patient with dementia experiences, we will discuss strategies to help you create a safe, nurturing environment for your patient and to handle common problems. Memory loss, with accompanying confusion and disorientation as to time and place, are usually the first and most obvious symptoms of cognitive impairment. There are 3 parts to memory: learning, remembering what you've learned or forgetting it, and retrieving stored information. As we learn and store what we've learned, we can communicate, give and receive messages. A dementing disease disrupts the process, so information can no longer be added or retrieved easily, if at all. Because memories are lost, the patient has no past to rely on. He is lost in an unfamiliar world, frightened, confused, and frustrated, unable to communicate his needs. Encourage patients to confide fears and frustrations. Listen with empathy. Show acceptance, patience, and compassion. Anything you can do or say to make your patient feel safe, secure, and cared for, and to build self-esteem is important. Use lots of nonverbal communication to reinforce your words. Point, gesture, smile, hug. When the patient can no longer understand words, these are the only means of communication possible. Because of the memory impairment and confusion, the patient with dementia often cannot carry on a conversation. His speech may be slurred or slow. He may use incorrect words or not be able to come up with the right word. Be sure that sensory deficits are corrected, if at all possible. The patient should wear his glasses and hearing aid, put in his dentures. Include your patient in conversation. Do not talk above, around, or over him. Stay where your patient can see you as much as possible. Use simple, short, familiar words and sentences. Your patient cannot understand complex sentences or forgets them immediately. Speak slowly and clearly. Allow ample time for response. Rushing will increase confusion. If the patient uses the wrong word, substitute the correct word, if it does not upset him. Continue to talk to your patients even when the response is minimal or inappropriate. There are specific behaviors which are common in patients with dementia. The patient will ask the same question over and over.
Where's my cane?
Your cane is here, Donald, on the table.
Where's my glasses?
Your glasses are here, Donald. You're wearing your glasses.
Where's my cane?
Your cane is here, Donald, on the table.
Provide reassurance in your answer, in your tone of voice, and in your body language. Your tone of voice is as important as the words you say, maybe more so, because the patient can sense your emotions. Never sound irritated or answer curtly. Loss of memory also results in disorientation. The patient does not know where he is, who you are, what time, day, or year it is. Donald frequently talks about his parents, who died years ago, as if he were still living with them.
I'll eat when my folks get home.
No, Donald, they can't be here, but I'm with you.
Though he has lived here for over 30 years, Donald frequently asks to go home.
I want to go home.
I know things don't look familiar, but you are home. This is your cup, your pipe, and your cane.
Try to place familiar objects within sight. A favorite chair, picture, or view from the window might reduce anxiety. Distraction is a useful technique which you will probably rely on often.
Where are my folks? I want them to take me home.
They're not here, Donald, but I'll stay with you. Let's look at this photograph album and see if we can find them in here.
Reality orientation is a technique used to reduce confusion and withdrawal by encouraging the patient to think. You repeat the same information about person, place, and time at intervals. To maintain orientation to person, call the patient by name to reinforce his identity, and use names when referring to others. Wear a name tag and ask your patient to identify you. Visual aids are helpful to reorient the patient to location. Use labels to remind the patient what objects are used for. Keep an object that is spoken of or requested frequently where your patient can see it if possible, such as Donald's cane. For reorientation to time, put the clock where the patient can see it and point out the time. Cross off the days on a calendar. Holiday decorations may offer reminders of the month and season. For example, St. Patrick's Day is associated with the month of March. Because abrupt changes in schedule can increase disorientation, it is very helpful to provide the patient with a daily routine. Follow the same schedule every day. Dementia also results in intellectual changes. The patient cannot make decisions, loses his train of thought, and cannot understand simple directions. Because of these losses, it would be very easy for you to take control and do everything for the patient. However, as a caregiver, your challenge is to promote the maximum independence in your patient. Just because the brain doesn't work as it once did, doesn't mean the patient with dementia can't do things. Help and encourage the patient to perform simple, safe, and doable tasks that are within the limits of their abilities, but still provide a challenge. Exercise and activity can stimulate the appetite, promote sleep, provide an outlet for emotions, and relieve boredom. Familiar chores are therapeutic. Actions that are repeated over and over are well tolerated. Dusting, wiping dishes, raking the lawn, sorting tools, knitting, sorting buttons, folding towels not only occupy time well, but may make the patient feel productive, useful, and important. When working with the patient, show interest and enthusiasm. Praise even modest accomplishments. Don't expect correctness. What's important is that the patient is active, doing something pleasant, enjoying your company, maybe feeling useful. As Ruth prepares lunch with Donald, she applies the principles of talking and working with the patient as we have discussed.
Donald, how about helping me fix lunch?
If he looks as though he didn't hear, wait a minute and try again. You might go closer and touch him to focus his attention. Use the same words to repeat questions or information.
How about helping me fix lunch? I'm getting hungry.
Explain and demonstrate what you want the patient to do in clear, simple, step-at-a-time directions as you go along. Reinforce with actions, pointing, gesturing, touching things.
Put the peanut butter on the bread like this. You like peanut butter.
Peanut butter and...
If he can't find a word or finish a sentence, offer a guess. If you don't understand what he is trying to say, encourage him to point or gesture.
Bread. Donald, what do you want? Point at what you want.
I like that.
Jelly. I like jelly too. Now put the jelly on your bread. Oh, jelly and apples. That sounds good too.
Have fun working together. Maintain a sense of humor and a cheerful mood. Even if the task seems silly or useless, create joy. This might be your chance to put a little sunshine in your patient's life. Personality changes are often an unfortunate part of the dementia picture. Donald also experienced many changes as the disease progressed. He began to wander aimlessly from room to room day and night, opening doors to peer inside, as if searching for someone. Wandering can be a dangerous problem, particularly if the patient wanders outdoors or while others are asleep. Be sure to discuss ways to assist the patient who wanders. It is not unusual for people with dementia to have delusions. When a person believes something to be true that is really false, that is a delusion. When he blamed Ruth for stealing, that was a delusion. Patients often become suspicious and paranoid, blaming others for what they can no longer understand.
What are you looking for, Donald?
Ruth took my glasses.
I know you're upset. Why don't I help you look for them?
Logic and reason will not work for the patient because the delusion is real to him. So you cannot argue, insist, or confront him to face the truth. You risk agitating an already fragile personality. Provide calm reassurance and assistance. In this example, Jerry responded to the fear and anxiety Donald had experienced without accepting the false idea. Hallucinations are not simply beliefs. The patient who is hallucinating actually sees, hears, or in some way experiences something that is not real.
Donald, why are you taking your shoe off?
That fella told me to.
This is a plant, Donald. Why don't we just move it out of our way?
Some hallucinations may be harmless, such as pleasant conversations with an imaginary friend. Ignore harmless hallucinations. Confrontation may make the situation worse. Sometimes it helps to control the environment to protect or ease hallucinations. A picture or knick-knack may remind the patient of a talking face. Don't turn on the TV or radio. This may be the source of voices. Some hallucinations, however, can be dangerous. The voices may tell the confused person to do something that would be hazardous to themselves or to others. You must do what you can to keep the patient safe. Many persons with dementia can experience sudden mood swings, anger, and severe agitation. The dearest, most mild-mannered person can be calm one minute and begin to shout the next. The mood swings and language can create pain and embarrassment for the family.
Let's put your shoe back on before your foot gets cold.
No! Get away!
Okay, I'll let you be for a minute.
If your patient becomes violent, do nothing to further provoke him. Never ridicule or talk down to a patient. Treat them as adults with dignity and respect. Names like sweetie or dear can sound patronizing. The patient is not responsible for his behavior. Sometimes it helps to step back for a short time, so the extreme agitation and frustration can pass.
Donald, I brought your harmonica. How about playing a song for me?
I can't remember songs.
That's okay. I like your music anyway.
Here, a timeout worked well for the patient, followed by distraction. Different methods and diversions will work on different days. It is more important to read his feelings than to hear what he is trying to say. Some days, nothing will work, but try. But be sure to pay attention to the patient's tone of voice and gestures. Stay serene and supportive. If your patient experiences episodes of violent behavior, be sure to discuss strategies with your supervisor. The primary concern is the safety of the patient, family, and caregiver. Caring puts a terrible strain on families, especially the primary caregivers. Often, you are their brief respite from round-the-clock duty. They too will need and benefit from your words of comfort, support, and hope, your positive attitude, and your efforts to improve the quality of life for everyone. While decline and loss pervade the book of dementia, they do not tell the entire story. The quality of a life that was and that continues must mark each chapter and provide a theme of hope and love. As memory fades and tasks become ever more difficult, most important for the patient is the assurance that he will always enjoy a comfortable, safe environment, be treated with dignity, and be given competent, loving care according to his individual needs. Let's review what we have learned about therapeutic communication with the patient with dementia. What is the golden rule to remember when caring for the patient with dementia? What are 3 common behaviors the patient with dementia may exhibit? Can you identify one technique for dealing with each behavior? What is reality orientation? Now we will discuss the second condition which challenges therapeutic communication, aphasia. Aphasia is a loss of or decreased ability to use or understand language because of brain disease or damage. Patterns of speech learned throughout life are interrupted, and the patient cannot receive, process, and express thoughts, ideas, and information properly. Although aphasia can be due to a variety of factors that alter or destroy brain cells, such as trauma, infections, toxins, and tumors, it usually results from a stroke, especially in older patients. A stroke, or cerebral vascular accident, CVA, occurs when a blood clot or hemorrhage impairs the blood and oxygen supply to brain cells, causing the cells to die. There are different types of aphasia. A person with expressive aphasia can think and can usually understand what you say, but cannot put their own thoughts into words to respond. It is as if your mind goes as blank as the screen on a broken television. A person with receptive aphasia does not understand what you are saying. There may be mental impairment, confusion, memory loss, almost like someone speaking to you in a foreign language. These patients know you are talking to them and may listen intently, but your words mean nothing. They cannot interpret your message. They may ramble on and on with words that are grammatically correct, but make little sense. The third type is global aphasia. Sometimes damage to the brain is so severe that patients use only automatic speech, such as slang or repetitive counting. Each patient you care for will experience different symptoms and degrees of dysfunction, depending on the type and amount of brain damage. Most patients have some degree of both expressive and receptive aphasia. Typical symptoms include inability to understand the meaning of what is said or written, reduced ability to read, write, gesture, or use numbers, speech that is slow, halting, slurred, often limited to short phrases or single words, such as names of objects or actions, inability to name objects or people, use of incorrect words, phrases, or sounds, repetition of words, phrases, or sounds, inability to organize ideas and express them clearly. Almost everyone can benefit from therapy. Patients are referred to a speech-language pathologist as soon as it is practical, often within the first few days after suffering a CVA. After testing, the speech-language pathologist will develop a program for the patient. The program will be based on the patient's language skills before the stroke, remaining language skills, functional losses, existing medical and emotional problems, motivation, family support, attention span, and the time elapsed since the stroke. The program can include a variety of exercises and drills, including flashcards, matching words with pictures, and practicing words and sounds to help regain lost skills or retrain the patient. Follow the home therapy program that is described in your care plan. Be sure to record the patient's day-to-day response, attitude, and communication abilities. When working with aphasic patients, accept them as they are. Offer encouragement, praise, and reassurance. And above all, treat them as normally as possible. Show your patient through your words and actions that you understand that their mind is working, but they cannot say what they want to. They have not lost their intelligence. These general guidelines will help you to facilitate communication and to ease distress and frustration in your patients. Be sure you gain your patient's attention when you speak. Include in conversation. Keep messages simple, with short, single-idea sentences. Idle chatter is confusing. Speak slowly, clearly, naturally. No louder than necessary. Repeat when necessary in a calm voice, or rephrase your message for better understanding. Ask questions that require only yes and no answers whenever possible. Be careful, your patient may say yes and mean no. Be sure to check the exact meaning. Be patient. Don't interrupt or answer for your patients unless it is necessary. If you allow enough time, the patient may be able to form thoughts into words. Never pressure the patient to respond. Don't dwell on errors. Use nonverbal cues, point, gesture, touch, to reinforce your message. Keep the atmosphere light and non-stressful. We'll look more closely at some of the specific difficulties created by aphasia, which can interfere with care delivery. Julia is recovering from a stroke suffered 5 months ago. With physical and occupational therapy, practice, and determination, motor skills have returned. Overcoming aphasia has been a slower process. We'll observe Julia and her home health aide Sandra as they demonstrate techniques to overcome the barriers created by aphasia. Loss of the ability to name things is a common problem. Your patient may know what the object is, but be unable to name it, or call it by the wrong name.
This is a chair.
Instead of telling the patient what the item is, try word association.
We read book. Read book. Right.
Difficulty producing sounds in the proper order often results in unusual word combinations. Sounds and words may be turned around.
Boeing Sasket. One more time. Take your time, Julia. Sewing Sasket? Okay, very good. That's good. It's a sewing basket, but that's very good, Julia. Sewing.
Sometimes, patients will substitute words from the same category.
And a part of your lunch. Orange.
Some patients cannot understand multi-step commands, such as go into the bathroom and wash your hands. Using one-step commands reduces frustration.
Sit down here, Julia. Sit down. Take the markers out of the box.
Your patient may also exhibit different types of speech patterns. Julia's speech is sometimes limited to short words or phrases. Frequently, smaller words are left out, and a sentence is cut down to key words, like a telegram. This is called telegram speech. Word order may be turned around.
Home. Daughter? You want to know what time your daughter will be home. She'll be home at 3:30.
If your patient cannot recall a word or topic, they may talk around it. This is called circumlocution. Julia is trying to explain to Sandra that she watered the plants.
I put this for my plant. You use this for.
Or the patient may speak in nonsense words and jargon sentences, rambling on and on. This is called lack of inhibition.
Well, if I would shide the drive with shop spread to the elm and, lolling.
In these examples, the patient chooses incorrect words, makes up words, eliminates words, or puts them together incorrectly. Because she may not be aware of these bizarre patterns, don't try to make corrections. When your patient experiences these problems, fill in the blanks as necessary. However, your patients will not relearn speech if you speak for them, so move slowly. Encourage every attempt. Try to understand your patient, repeat the meaning, and have her verify it. Remember, too, that the patient's ability to communicate changes throughout the day. The patient who is tired is more apt to become depressed, agitated, or unable to speak.
What are you trying to say, Julia? You want to go to the bathroom? Okay, if you want to go to the bathroom, squeeze my hand. Okay, I'll take you to the bathroom.
If communication fails temporarily, offer comfort and support. Tell your patient that you are sorry and acknowledge their frustration. Then try again later. Work out a system to communicate basic needs if at all possible. Experiment with other methods. Point, use other hand signals, blink, pantomime, draw pictures. Cards with pictures of daily needs are helpful. At all stages of recovery, tablets, blackboards, magic slates, and spelling boards are useful, depending on the person's ability to write, move their hands, and make connections between words and objects. Family members and friends also experience the fear and frustrations of aphasia. Often they do not understand what is happening and are not prepared to handle the communication barriers. They may treat the patient like a child, not realizing that just because they cannot communicate does not mean they cannot hear, are confused, or cannot think clearly. Wishing to be helpful, they anticipate needs and speak for the patient. Julia's neighbor is very concerned about her condition.
Hi, Sandra. Hi, Julia.
Hi, Marianne.
I brought you some cookies, honey. You really look cold. Let me put your Afghan on you and we'll bundle you up just like a little baby. Julia needs special treatment. She can't even talk. I'm afraid she'll never be normal again.
But Julia is improving. She's doing a lot better. She'll let you know when she's cold now. Oh, Julia, look, you have cookies. Would you like some tea?
Tea.
Yes.
Good.
Okay, I'll make tea for you.
Good.
Julia's neighbor means well, and her visit is important to promote socialization. But it is also important that she be part of the team, supporting and encouraging Julia. Here are some hints for you to share with friends and relatives. Never talk down to a patient. An adult must be treated like an adult. Never say things you ordinarily would not say in the person's presence, even if you believe they do not understand your words. It is impossible to know exact levels of comprehension. Talk with the patient. Include them in activities. Sometimes, because of damage to the brain, aphasic patients who would normally never use it may use profanity. Do not draw attention to it. The patient has little control over it. Encourage patients to be active and involved with familiar pastimes, leafing through magazines and newspapers, helping fix food, gardening, knitting, hobbies. Speech will come easier, and mistakes will be less disturbing if they are working on projects they enjoy. The road you travel with your aphasic patients is a single lane, marked by time and compassion. You must communicate at a level that will be therapeutic for them. Try to understand your patient's communication problems. Implement techniques which will build on their strengths and reinforce their areas of need without creating undue stress. You have the knowledge and skills to motivate and help your patients achieve the best of their ability in the rich world of therapeutic communication. Let's take a minute to answer some questions about the patient with aphasia. What is expressive aphasia? What is receptive aphasia? What are some specific problems the aphasic patient may experience? How can you deal with these problems? What are some hints to assist friends and relatives of the aphasic patient? Caring for the patients with dementia and aphasia will not be easy assignments. Effective communication must continue despite the physical, emotional, and mental impairment on the part of the patient. The burden of responsibility to understand and make yourself understood falls on you, the caregiver. Recognize the individuality and unique situation of your patient. Listen to the patient's verbal and nonverbal language. Demonstrate a caring and kind attitude, and adapt your effective communication skills to meet the patient's individual needs. Through therapeutic communication, you can overcome the challenges presented by dementia and aphasia.